Dan,
Yeah.
are you sure mental health is not being bewitched? I mean, ndio maana spendangi script. I read this video is very informative. You see now, when you have not told me hizi vitu, now we can continue. Sindio? How did you come to the UK as a mental health nurse? Now let's talk about your practice in the United Kingdom. The other day when we talked, you told me, and I'll quote, I am so happy that I've worked in the United Kingdom. It has made me open my eyes with regards to policies that surround mental health. So, Dan, what difference exists between how United Kingdom approaches mental health and how Kenya does the same?
So like as a person who has practiced both in Kenya and in UK as a mental health nurse, it's quite a lot. There's quite a lot that probably we need to borrow from the UK, which are good practices in terms of mental health. Because like for me, moving from Kenya to here it was a paradigm shift, you know, moving from old to new. So one thing that I've realized about the UK, well, in Kenya still there is the Mental Health Act. But if you look at the Mental Health Act in UK, it's structured in a manner that it's to both, you know, the user and to both the practitioner, there are rights that all of you are entitled to. So I'll say in the UK, mostly like mental health is purely governed by the Act.
Okay.
That is the Mental Health Act, 1983. So that is the Act that we use here. So it specifically stipulates, you know, the modalities for admission, the modalities for sectioning a patient, for how long, the treatment options, you know, the rights that the patient is entitled to. So those are some of the things that are clearly stipulated in the Act. But you look at mental health in Kenya. So it's quite unfortunate that it's sort of left to the medical fraternity, as opposed to here. Here it's like it's sort of I'll call it's multidisciplinary. So in Kenya, mostly mental health is left to the medical people, like it's mostly medicine only. So like if for point in practice, if you've ever taken a patient to Madare, so you realize the first thing they want to is to jab this patient, medical. So it's chemical restraint. But if you look at the UK and the Act, how it stipulates, so one of the things about the Act, it advocates for less restrictive options. Okay, so less restrictive means even if this patient comes to you very violent, very aggressive, before you even think about let's, you know, give this person injection to calm this, I mean that's chemical restraint. Before you even restrain this person, you're thinking about, can we have a conversation? Can we sit down? Can I take this person to the garden, probably just to, you know, help this person look whatever was a stress, or rather what was you know, activating this. Can we try and identify what this could be and calm this person down? So you're trying another option, trying to take this person to the garden. You're trying even to offer cup of tea. So we call it cup of tea
Cup
here.
of tea, of course.
Yeah, so it's not cup of tea, it's a cup of tea. Yeah, so we want to offer this patient cup of tea. We want to, you know, we want to basically we're trying to, the last resort here will be use of restraint. Okay, and if I was to use chemical restraint, in this case injection, then I need to do detics. So it's quite a procedure. So the Mental Health Act here in the UK stipulates for less restrictive. At the same time, it maximizes on independence of the patient. So that means as much as you're dealing with this patient, you're allowing this patient the, you know, the freedom to do what they can do.
Okay.
So if I was to juxtapose this with what happens back home, so in Kenya, so the first thing would be this patient come very violent, aggressive. So we just want to jab this patient to sleep, or first of all, before we even, you know, give this person the opportunity to even learn from, to express themselves. So that is one of the difference. You look at, again, things like, once a patient has been admitted, so like here what we do, once you've admitted your patient, within the 48 hours of admission, so you've read the patient, his or her rights. So you've read to the patient what we call the 132 rights. So you've told this patient, look, we've admitted you here, but you have the right to accept or refuse treatment. Okay. That takes me back to the Mental Health Act. So the Act still again stipulates which kind of patients who can be forced into treatment, and those who have the liberty not to agree to treatment.
Wow.
So you also explain to this patient, no, this is your RC, your responsible clinician, this is your nurse. So your nurse, you as the named nurse or the nurse who takes care of this patient. You have to sit down with this patient. Then you are going to develop what we call patient-centered care plan, right? When I practice in Kenya, well, I wouldn't say that it's lost. Mental health is lost there, but I can't remember where I was sat down with my patient, or just to discuss what the preferences are, what has worked for you before, So those are some of the things that probably are missing. That the healthcare system in Kenya can still borrow from the United system. Also, things like Section 17 leaves. So these are once a patient has been admitted. So in Kenya, if your relative is admitted in a mental health institution, I think the next time the patient leaves is when probably the doctors are happy, everyone is happy that this patient probably is calmed down. That's when the patient will leave the doors. But here, so they have introduced something called the Section 17 leave. While a patient is still admitted, the patient has got liberty. So once the patient starts, the prognosis goes well. So they are given like 30 minutes, escorted leave with a staff member. They go out. Here, 90% of people, or rather 60 or 70, they smoke. So they are given those breaks to go for a fag or rather a smoke. Once they utilize the 15-30 minutes of leave, they now go to 1 hour. Then from escorted, they're allowed on their own to go to the center, to their shopping. Like I've said, they maximize on your independence. So by the time this patient is being discharged back to the community, this is a patient who now has been going out. So it's not really a big transition going back to the community. So as opposed to Kenya, where a person goes in an institution, that the next time they're going out is when they're getting discharged. So those are some of the discrepancies, or rather some of the differences. Then if you look at the referral system again also, if you were to compare how the UK system operates and the Kenyan system, is quite different. So the referral system here, it starts from the community. So it's very, and I've never seen, unless a person chooses to be homeless in the street, it's quite difficult here walking down the streets and you come across probably a person who is mentally unstable walking down the street, because the system here is such that every person who is known to have a mental illness, they have what we call the care coordinators in the community. Yeah, so these are people who keep track of these people. So, and when things start getting wrong, they will alert probably another level of people who are known as the crisis team. Remember, they are still not at inpatient level. This all operates within community level. So you have your care coordinator, you have the community teams. Under the community team, now we're talking about the crisis. So these are people who will move from houses to houses, just ensuring that people who probably have been discharged from services, they are getting the help that they need. So from the crisis now, these are the people. If now the person becomes, remember here the criteria for admission will be if a person is not safe to the public or to other people. So it's safety towards one, like towards yourself and safety to others. So if you are unsafe to both, so then probably you meet the criteria for admission. So the crisis, these guys who I'm referring to crisis, it's a team. So once they realize this person cannot be managed safely in the community, then they are going to encourage, they just now have to either give this person two options. Look, you're not doing well in the community, and we feel that you're not safe in the community, so we feel that you will benefit from an inpatient admission. So they will contact us where we work. So they will let us know. So okay, we have this patient that we feel that we might benefit from admission. So the patient will be given two options. So are you willing to go to be admitted as informal patient, or do you feel that it begs back to the question, mental health purely is between, there's something called capacity and insight. So it boils down to the two. So if this patient has got insight, they will agree to informal. But if, again, they feel that they are well and they can manage themselves, whereas the other people think they're not well. So the Act stipulates that this patient has to be assessed by two doctors. Okay, so the two doctors, one must be approved under the mental health. So they are called Section 12 approved doctors. So these are purely doctors who are like done post-grad and stuff in mental health. So they are approved under the Act. So one of the doctors must be Section 12 approved, then another doctor. Then there must be a person whom we refer to as AMP. This is a person with mental health experience. It could be a nurse, could be a social worker. So this person, once the two medical recommendations have been done, this one is the third person is going to do an application to an institution. So then the patient will now be brought in the facility as a section patient, or rather detained patient now. I'm trying to look at a situation a patient is admitted. Probably the military way of admission could be the one where two doctors will agree. But the other one, the involuntary, because in Kenya it's classified as a voluntary, involuntary, or the military. So the involuntary, any doctor who is in casualty at Madare, probably a registrar or someone, can, subject you to detainment under the act. So those are some of the things. And basically the reason why they're having these two doctors, it's because they want to get two different opinions.
That's very good.
Yeah, so those are some of the differences I'll point. There's a lot, but those are some of the differences I can point between the two.
Thank you. There's a lot of information you've just lectured me on mental health, and oh my gosh, my tutor in nursing school would be very proud. Madam Jailo Aswa, you need to talk to my friend Dan. He has a lot of updates as far as mental health goes. So Dan, two questions as we come to a finish. One will be, how can we reach a point of accepting that mental health is real and we stop stigmatizing people? Now, case in point, I have a friend of mine whom I once went for a coffee with, and in the middle of our coffee, she removed her tablets and put them on the table. I remember I think, a year old in the UK. Okay. And then she started putting them one by one on the side, and I happened to ask, oh, you're having some medication. Do you know what she told me? She told me, oh, I'm actually schizophrenic and I am bipolar. If I don't take these medications, I'm not going to be okay. And we continued with the conversation. I am yet to meet an African, a Kenyan, who has reached that point of accepting and us not stigmatizing them for the mental illness that they are dealing with. Dan, how can we demystify mental health? And like the way I can tell you, oh, by the way, I was diagnosed with malaria. Oh, by the way, I've been suffering from diabetes. Oh, I have been suffering from high blood pressure. How can we reach that level as Kenyans, as Africans, to say that mental health is here with us? And because if we do not accept what it is, then we will not treat it properly. Please help me.
Mental health is real, and it's there to stay. So one of the things that the government can do is lots of advocacy. We really need lots of advocacy at community level. And the advocacy should not just dwell on, telling people that mental health is there, it's real. The advocacy should also deal with things like cultural barriers. These are the things that, probably will limit people. People would think that probably because somebody is suffering from mental illness, this could be something related with culture. So once...
Dan, are you sure mental health is not being bewitched?
No.
You're very sure it's not witchcraft?
Like you've just mentioned quite well. So you want a situation where you'll walk in and tell someone, like the way I'll say, oh, I had malaria last week. Perfect. So mental illness, just like malaria. So these like mental illness, these are diseases that affect, if you look at the anatomy and physiology, so the diseases that basically are neurological related, these are, well, not all neurological, but these are the diseases that tends to affect, how we think, it's, so how we think, how we relate with people. So, and the moment we agree that anyone can suffer from a mental illness, then that's it. It all begins with you as an individual. If I was to ask you, Kate, if you were to go to see a GP or to see your doctor today, and he tells you, Kate, I think you're suffering from depression, how will you take that? Okay, so it starts by you. Once you've agreed to that diagnosis, so the next thing you want to go and talk about it. Let's be open. Let's talk about, like the way we talk about other illness. Let's talk about mental illness. So, like I've said, the first thing we need to do is to accept that mental illness exists. Then let's do advocacy to the people who still believe that you could be bewitched, or rather it's something to do with culture. Then the government of the day needs to come up with policies, policies that will specifically deal with mental illness. Okay, so policies, in this case I'm talking about things like, if it's employers, let employers be compelled. If it's at workplace, if probably somebody is diagnosed to have because we've seen cases where a person is diagnosed with mental illness, they've ended up losing their jobs, or rather they are they are laid off on basis that they cannot be able to function. And like I've told you, we have people who have got mental illness and they're still productive.
Yeah.
So once the government puts policies in place where people are compelled, to follow those rules, then I think as a country we'll be in the right direction towards demystifying the myth about mental illness. Another thing I think the government also needs to do when it comes to financing health, so there needs to be money specifically allocated to mental health. I know there is money allocated to mental health, but I don't know what percentage or what fraction, but I think the government of the day needs to, to look into putting more resources, because you realize that if you were to work probably in a facility right now, let's say for instance like Kiambu or whatever it is, so there are many patients who probably are suffering from simple things like depression, anxiety disorders, but they will present like patients who are suffering from physical illness. So there's lots of somatization, there's lots of mental illness that will present as physical illness. And if the government of the day can even set aside in each facility probably a room where we'll have someone who specifically is trained on mental health to deal with some of those cases, then I think we will be in the right way in demystifying, mental health, and we'll get rid of all this stigma that's associated with it.
So, Team Phoenix, thank you so much for sticking around. I don't know what to do. I told you that this is going to be in 2 parts, but oh my goodness, we have to stop this video and do yet another one. My goodness, we have so much information that we have to glean from Dan. We cannot let him go. Not yet, not yet, not yet. So, in the meantime, check out my socials. They will be in the description box below. And check out the socials for Dave Kim 254 Studios as well. If you want videography, photography, Dave Kim 254 Studios are your person. So let's see you in the next part, shall we?